Hello and welcome to the December session of the Medicaid Insights Colloquium, also known as the MIC. Thank you all for tuning in today. I'm John McConnell and I'm the director of the Center for Health Systems Effectiveness, or CHSE for short. We are a research center at Oregon Health and Science University in Portland, Oregon, and we've had the honor of serving as the hosting organization for this program. I want to take a quick moment to recognize the rest of the MIC Planning Committee for all their continued work in planning these events. Our team includes Will Shapiro from Cornell. Will is out on jury duty today. Sarah Gordon from Boston University, and Sarah is on paternal leave, and Jamila Michener, also from Cornell. And Jamila is going to be watching the chat and sharing questions that you might have for the latter part of the session. So today we have Kosali Simon joining us. Kosali is a health economist in the O'Neill School of Public and Environmental Affairs at Indiana University, where she is the Herman B. Wells Endowed Professor and also the Vice Provost for Health Sciences. Her research has been wide-ranging and influential, and she's been quick to pick up on changes in policy or the health system, and is often a first mover in using these changes to give insights about what's happening. She had a very influential early paper on the effects of the young adult mandate as part of the Affordable Care Act, showing that this policy had a much larger impact on covering people than most had anticipated. She has also looked broadly at the effect of the ACA and Medicaid expansion, showing, for example, that most states were able to expand Medicaid without increasing administrative spending. And in states that did expand, there were often changes outside the Medicaid program. For example, with states that expanded Medicaid having fewer people needing supplemental security income, suggesting some cross-program savings potential. At the onset of COVID-19 pandemic, she made an impressive pivot. And her team was first out the gate with a few studies using new data sources, often ones that we hadn't seen before, often very timely, just a few weeks or months old, to give insights on the effectiveness of various strategies to combat the epidemic. So we're very honored to have her share her insights with us today as she explores some emerging research on the role of Medicaid during the age of COVID-19, including the different experiences of states with and without the Affordable Care Act Medicaid expansions. So please join me in welcoming Kosali Simon. Thank you.
Thank you very much, John, and thank you very much to the MIC team for this opportunity. I am going to now start my slideshow. So I'm going to talk about this era we are in terms of Medicaid's experience, particularly with the provisions of the public health emergency, and see what is it that seems to be emerging as evidence on questions we are interested in knowing about, and what are things that new data might enable us to inquire about, which are important for policy decisions coming forward. So I'm going to talk about just how currently Medicaid program is at a key juncture, with enrollments being far larger than have been seen in the history of the program. There are over 90 million individuals now enrolled on Medicaid, and whenever I am mentioning Medicaid, I also mean CHIP and Medicaid. So as of August 2022, the latest numbers are this slightly over 90 million, and that is an increase of nearly 20 million enrollment since February 2020. But it is very important to understand how coverage numbers compare to enrollment, for example, and to think about how this program plays a really critical role in health equity. Medicaid and its expansions have been really a key reason, if not the key reason, for stability in health insurance during a public health crisis. So I'm going to think about the ways in which Medicaid has played this role by itself, even without any expansions, a social safety net for health insurance, especially for the under 65 population, was going to play a key role in a public health crisis. But it's because of the Affordable Care Act Medicaid expansion and the public health emergency Medicaid expansion, the administrative expansion, even if not changes in income thresholds, that we want to know how large a role those expansions played. So I'm going to also be trying to think about what we can learn from this period to help with the stabilization during the unwinding of the public health emergency time period, and thinking about also ultimately what we can learn then about the role of churn and health and well-being. So I'm going to start with a slide that illustrates just how important the Medicaid program is for health equity. This is 2021 data that I combined the Kaiser website estimates of the numbers on Medicaid, the coverage numbers, with just population numbers from the Census Bureau to show that by race and ethnicity, the percentage of individuals who are non-elderly, so the population under 65, as Census Bureau defines, that has coverage under Medicaid reported in the CPS in this case. It varies widely, and this is, again, something I think we have to really keep in mind when we think about Medicaid, that it is playing this equalizing role. It plays a really big part in health equity. So to put in context Medicaid policy during the public health emergency, there are, as we know, several these temporary provisions that expanded the role. These are the, I'm going to refer to as administrative expansions in Medicaid, as opposed to the income threshold and population definition expansions in the ACA. And there's also, the subsidies to the marketplace coverage became more generous, and that there was I'm going to focus on the suspension of redetermination and continuity of coverage provisions. The period leading up to 2020, there had not been a lot of Medicaid expansions of the post-ACA, post-2014 time period. So during 2017 to 2019, there were no states. From 2020 onwards, there have been a few states, but for the most part, states went into the public health emergency being either an expansion or non-expansion state. And these increases that we've seen in enrollment continue even, it wasn't just in 2020, even just during the year so far in 2022, we've gone from, in January, there being 87 million to now in the August data having 90 million. So these increases in enrollment continue, and there are studies that are forecasting what the impact of the PHE unwinding will be, and it will be really, really substantial. These numbers are really staggering, 5 to 14 million or 15 million, of which HHS estimates that roughly half will be people who are eligible, who will be losing coverage. So I'm going to also put this in context of the last Medicaid Insights Colloquium, in which Dr. Alker talked about just the nuts and bolts, what are the administrative processes and choices for states in unwinding. And so I will draw on mostly recent reports of insurance coverage that have been published, and then bring to bear a little bit of new data that covered through 2021 on particularly trying to get at what can we tell about healthcare usage. So I'm going to then wrap up by just thinking about what are the priorities going forward that we could be prepared for, and think of ways in which policy choices to come might find things that we could do, help the discussion. So first, a look at enrollment and coverage. So there is quite a lot that we have seen from administrative counts that CMS puts out, and that's where all those quotes about number of people enrolled are from. And then there's been also many reports. People have been very, very quick to analyze new data that has been from national surveys. And so we have many reports also on coverage. So this first is just a look at data from the CMS enrollment counts that include Medicaid, always will be including CHIP as well. And this is total where I split the totals by the time period and by whether it's an expansion or non-expansion state. So what you can see here is that there is, starting in the time period when the public health emergency goes into place, and the slope changes, and it's the eyeball test is that it changes, the slope changes more in the expansion states than the non-expansion states. And I should note, everywhere in the graphs where I'm going to show expansion versus non-expansion states, because this is covering a period of 2018 to 2021, I will have removed the states that had any expansion activity during that time period, these states that are listed at the bottom, because then that would keep the composition of states between the two lines the same. So there's clearly no question enrollments have been increasing, and that there is this differential enrollment increase in expansion versus non-expansion states. But what do surveys show about what people report as their coverage? That has been a little bit of a surprise at the start, but then we have to ask, is that a surprise, or what do we do with the fact that they are not showing the same trend? So there are many studies. I'm just going to highlight two that have been in the very recent past months. In this first study, this is the Census Bureau work that shows uninsurance reduced in all states but one, North Dakota, in comparing 2021 to 2019, and that these are visible both in expansion and non-expansion states. The next slide will have the graphic from that paper that shows that. Public coverage is seen as the reason because private coverage does drop. And in public coverage, the increase is almost all from Medicaid. And see the increase. I'll go to this slide and come back to the other bullet point. So this is the figure in that analysis that shows the change from 2019 to 2021 by state, and you can see that the blue bars at the blue dots at the bottom, which are the non-expansion states, there too, the number for 2021, which is the light, you can see the dark colors and lighter colors are lined up so that uninsurance has improved. There's a decline in the share of people without health insurance. So what about other studies than the first one? This one is using data from the American Community Survey. There have been papers that have looked at other data sets as well, but one thing that was done as a follow-up to the first study is just to say there was this really large increase in Medicaid enrollment, but coverage for Medicaid, even though there is this increase 1.3 percentage points, it's not as much as as would correspond to the enrollment increases, and therefore this is evidence of what we know has been the case in the past as well, a Medicaid undercount. That is, individuals who formally are covered by Medicaid or formally have an enrollment record in Medicaid may be reporting themselves as uninsured or insured by another source. So this is a Medicaid undercount. And what this report does is show that this undercount has actually increased. So it's not just that it has existed and it's part of what we're seeing now, but the extent of the undercount is larger. And so it's very likely that continuous eligibility means that people who are enrolled are not as aware as they would have been under a scenario of needing to do re-enrollment paperwork, that they might be still enrolled. So the extent of the undercount, according to Hess et al., is that in the pre-pandemic period, it's about 7 to 8%, and that in 2021, the undercount is almost double that, And there's a very clever way in which they look at the extent of undercount. Essentially, they look at people who are in 2021, the CPS that reports coverage for last year, looks at their answers for 2020 and says, longitudinally linking the half of the people in the CPS who continue to be there. If you said in 2020 you had Medicaid, and because of the PHE, we know you are Medicaid and enrolled by those statistics, how many people now say that they don't have Medicaid? And that's been a really, I think, a very clever way to look at what the undercount is. And so that undercount shows that uninsurance is overstated by about 17%, because many of the people who say they're uninsured actually are likely Medicaid enrolled. So here's the graphic from that paper, which shows how this undercount, the phenomena that was 7 to 8% before, has now risen to 15%. The difference between the enrollment and the ACS reported. So there are other studies. Another two here I'm highlighting are from the Urban Institute that do simulation work that says, what if the public health emergency extends longer? What would happen? Of course, that does mean that as more people get added, the number who would then lose coverage from an eventual PHE ending will be larger. And that most of this enrollment increase is from continuity of coverage, versus we could be thinking maybe it's because economic conditions are worsening and more people are actually qualifying, but these studies show that it is the public health emergency continuity of coverage that seems to be primarily responsible for these. So this, the second bullet point here, the McMorrow et al. Study looks at, well, what if we look at other surveys, not the American Community Survey, and shows that there is essentially flat coverage changes in lots of categories comparing 2019 to 2021. And again, uninsured, not much of a change in uninsured. So the takeaway from these survey results compared to the enrollment numbers I showed at the start is that there's a disconnect between those. And so I think the question that arises is, what does that mean? How can we get at trying to understand what that is a little bit more? And so I'm going to now show some results from looking at actual transactions. That is, there is enrollment, there's coverage, but then we might actually want to look at what healthcare is being used, what dollars are being transacted, to think about how much of the new Medicaid enrollment might be actually actively using the coverage versus are more passive or might even not know that there's coverage, thinking that this might shed some light. So first, I'm going to look at data from a source that has been collecting information for a large number of years, from at least from the 70s onwards. You can download this data, where there is tracking of federal transfers to local levels, and aggregate them to the state level, but also down to the county level. There are other sources for these type of financial transfer data, from the annual survey of state and local government finances, for example. But this is a source, this Bureau of Economic Analysis Regional Economic Accounts, which has data up till 2021 now, and this is called the Regional Economic Information System. So it's from National Income Accounting, and from the late 60s, has been tracking not just Medicaid, but other social insurance programs, transfers from the federal government to local areas. So this, I want to make a note that this is both fee-for-service and managed care, and that these data come to the Bureau of Economic Analysis from CMS. But an important caveat is that there's a note BEA puts in there that some states and years are imputed, but we don't really have much information on what it is. So I don't know how much of this is what we can think of as if there has been imputation, for example, in 2020, but I'll compare, I'll look mostly at 2021 to 2019 comparisons. And as far as we know, this seems to be, if we're looking for how much has gone to local governments, the best source for federal government transfers. That's what we could, so here's, again, aggregating these numbers in the same way that I showed before, separating states by whether they are non-expansion during the entire time period or expansion during the entire time period. There too, there is this rise that happens going from the 2020 numbers are higher than the 2019 numbers, and the slope has increased more for the states that are expansion states. So to the extent that these show that care is being used, money is being transferred, that difference in slope shows up here too. So the next things I would be interesting to see would be to see at the state level or getting down to the county level, how do conditions that took place during these years correlate with what we see in these transfers? Did more of the Medicaid transfer dollars go to places that had higher unemployment rates or other ways to measure burdens, and also differences by baseline conditions, heterogeneity of populations, equity in where the extra money is going. So I want to make a note about unemployment rates in particular, because going into the COVID recession, everyone had on their minds how recession and health insurance and health are linked, but we also knew that this was going to be a different recession. So even though there were these large unemployment rates at the start, it quite rapidly changed, and the losses associated with private health insurance, we don't know if those are as large as they have been in past recessions, partly because employers were not sure if this was going to be very temporary and whether the people were going to stay on health insurance just as a measure of, well, we're going to call you back, and so maybe private health insurance wasn't going to drop as fast. The other reason for thinking that the relationship between unemployment and uninsurance was going to be different is because this was the first post-ACA recession, and so we knew that there was going to be more protection anyway, even if there had not been a public health emergency provision to change Medicaid rules. So I'm going to now think about what we know about actual healthcare use in Medicaid and see again if that can shed light on, has there been a substantial change? Even if there are dollars flowing to states under Medicaid, especially in the case of managed care compared to fee-for-service, dollars may still flow even if it's not as connected to people's actual use of healthcare, because managed care is being paid regardless of whether the fee-for-service services are going to be delivered. So could be that that's not a good test of actual healthcare utilization. So thinking of what data to draw on to think about healthcare use itself, the state drug utilization database, the SUD data that CMS puts out, is a very quickly available data source that is much easier to get access to than, there'll be much better research that will come out using TMSIS and other data, but this is available right now through the first quarter of 2021. I stopped the series at the last quarter of 2021. The first quarter of 2022 is available, but sometimes it takes a while to complete it, so I did not draw on that data. The fourth quarter of 2021 is the last data point. So these are reported to CMS by state Medicaid offices that show at the level of the individual type of drug. So the National Drug Code, the 11-digit version, which shows exact packaging sizes, all that down to that level, can see how many prescriptions were filled and reimbursed by Medicaid in a state at the quarterly level. So I'm now showing the totals, national totals that come into Medicaid. And this is showing the drop that happened in all types of healthcare use. We know as soon as the pandemic hit that many people's medications, typical use of other healthcare did decrease a lot, and that it came back only gradually. So now we are as in fourth quarter of 2021, the numbers are right about where they were in January of 2018. So it has taken a long time to get up to the total here that was pre-pandemic. I'm going to now look at this again by states with and without Medicaid expansion, as well as by class of medication. So we might want to know, well, even if the total number of prescriptions are different, what has happened by particular classes of medications as well. Before that, I'm going to split the data by whether it's fee for service or managed care. So first, just showing the total for managed care, which is more of the total number of prescriptions covered by Medicaid are under managed care, and drawn a line for the public health emergency time point. You can see there are slope changes in both, and the slope change for the managed care looks, the eyeball test looks larger, and that they both rebounded, but it has, there is slightly less of an increase in the fee-for-service products. These are just all eyeball observations on this. So next, just separating it by therapeutic class. So from the National Drug Code, it's possible to link the medication to the broad class to which they belong. And I'm using here the classification that's called the anatomical therapeutic class, ATC categorization, which is by like body system. And so these are the categories. I'm not going to go too much into interpreting or understand. Like, I think this is just a first look at, be interesting to understand more of the drop that happened, and that there are increases in certain categories. And would love to know, for example, from clinicians, whether these are substantial changes in the composition of medications, and what can we make out of how these patterns don't look like they're identical across all of the different therapeutic classes. So now this is a slide in which I look at, again, separating by the type of whether they're expansion states or non-expansion states. And here too, we continue to see this pattern that something looks different in expansion states. So this is not just looking at enrollment numbers, but looking at as close as possible to actual healthcare utilization. Even if coverage changes don't look that different, there seems to be perhaps more of a visible difference between expansion and non-expansion states in utilization. Again, this is just a very preliminary look, and very interested in thoughts people have about more ways to dig into this and see what more we can tell. So again, just as a very preliminary look on the puzzle that seems to be emerging in the PHE literature, that enrollment numbers are very high, but the relationship between enrollment and coverage is unclear. And we'd really like to also know what those trends are like by subgroups, and maybe going to look further at actual healthcare use or dollars transferred might help us understand that puzzle more, because I think there's lot of implications from understanding if enrollment increases but coverage doesn't, is it, and different ways of interpreting undercount. Is it that people have the coverage, know that they are eligible and or know that their enrollment continues, but are choosing to report another source of coverage? Or is it that more outreach would have helped them to understand that they had that coverage still? I think there's a lot of questions there that are unanswered. And that all of this is again towards a goal of seeing how this PHE expansion, which I'm going to think of as a Medicaid expansion, but a Medicaid expansion of an administrative type, how does that and the reduced churn that happens from it, how does that impact ultimately health and well-being? We're looking at coverage, enrollment, healthcare use, but really the end goal is to look at health and well-being. And I'm right now just doing the most crude look in terms of just national trends by categories of states, but what are some study designs we could come up with to try and assign more of a causal interpretation? So, for example, there are categories of individuals for whom, whether they fell into a certain category on the day before March 18th, which is the key date that was used for deciding whether your continuity of coverage applies or not, whether people were on that, were in that category right before or right after makes a difference in whether the continuity provisions apply to them. That could be a study design that's used to look at these questions further. There's also more, just looked at a couple of data sources. There are lots of data sources available that could shed light. And also just to keep in mind that what we want is, so one of the reasons for wanting to use close to real-time data is to help prepare for this phase out that we know is likely to occur at some future date soon, and that lots of effort is going in by the federal government, by states, by lots of organizations to make that as disruptive as possible, because we can tell from all the numbers we know so far that it is going to impact a lot of people. So I'm going to stop my screen share and turn it back to John.
Yeah, thank you so much, Kosali. That's really great. So we've got some time for Q&A. I've got some of my own and some from the committee that we pulled together, but would encourage anybody who's listening and wants to drop questions into the chat, put those in there, and I'll take a look at them, or Jamila will take a look at them. But to start, I wanted to ask about some of the data sources that you've used, because it's possible that not everybody here knows about them, and some of the ones you showed here are maybe a little bit more familiar in terms of the administrative data, but kind of early on, I think I saw you presenting some things where you're pulling really recent data from all sorts of new data sources. That's probably, it's not quite 3 years ago, but going back pretty far. And so I wonder if you could sort of talk a little bit about, I'm assuming that you've had experience in those, and there's ones that you like more, or maybe you're getting, sort of getting your kind of grounding in how these are really going to work. So I wonder if you could pick, 2 or 3 that you think are promising that people might want to think about and understand, and sort of what you can do or can't do, and how difficult those are to work with.
Yeah, sure. So the things I showed so far were just from publicly available data that anybody can download and quickly make some graphs out of. But I think really exciting things will come from people using more individual level data, which they'll have access. So of course there is further and further work that can be done with the surveys that were mentioned. I think the reports so far have really, they've been fantastic. They have been quick turnaround, get the results out fast, national looks. So subgroup analyses, trying to look at linking to data sets that might have individual health conditions. I think a lot more will come from just even more of exploiting survey data that's available. But beyond that, the real-time access to electronic health records that many people have figured out different sources of where to get that. There is the COVID N3C NIH initiative that has now collected from something like 60 different sites a pooling of electronic health record based data. That is a really great resource. Then different states. So Indiana, my state, has a state-based electronic health exchange that allows applications for research, and that is going to be a source we are hoping to have some research out of that would, so depending on people's states or other access, the COVID-19 research database that was under the DataVant organization as a Data for Good program now continues under another organization, it's transitioned, but it is still available to researchers for applying for these kind of proposals. I think people who have access to Medicaid TMSIS data that might be accessing it through the virtual research database rather than waiting for the physical files. I don't know how fast that access is, but I think it has gotten to be pretty fast. So I imagine that people with that access will be using that to look at people who have been enrolled after March 2020. What does their utilization patterns look like compared to other years? So those are just a few types of data resources I think people will.
Yeah, great. That's really helpful. I'm wondering, sort of turning to kind of methodologies. You've kind of hinted at a couple there, but when I'm talking to colleagues and various researchers, there's a lot of questions out there that are framed as something along the lines of, well, we're really curious about the effects of COVID on X, and sort of the challenge that they're facing is that everybody wants to do some sort of diff and diff, but we've got COVID kind of broadly affecting everybody. I think one way that you split it is well, we know these things are going to have impacts, but maybe they'll be different, whether the states were expansion states or non-expansion states. You mentioned sort of the this March 18th cutoff is sort of another thing, but I wonder if there's other ways you've thought about, how do we, when we're thinking about sort of quasi-experimental thing, what can we do to sort of move beyond this, the simple thing is just sort of a pre-post, but what can we do to get more causal estimates? And so I wonder if you have, things that you'd be willing to share in terms of how you're thinking about that, given that the epidemic really, came all at once and sort of hit all at once. Maybe there's a little variations in there, but how are you thinking about that methodologically?
So I think the first one that just came to mind was the diff and diff by ACA expansion status and before and after PHE, which is just the eyeball version I'm doing on the graphs, thinking, well, of course, that's going to be a hard sell to whether, how does that meet the assumptions of a diff and diff? And so at least first, just starting off by looking at what are pre-trends like, and just do a whole host of things that say, here are the threats to validity, but there is something to be learned. It does answer a particular question. It answers the question of assuming that the decision, especially, and it's tenable, especially because those decisions ended by 2018. Like you can find the large group of states that had no activity after 2018, and you say can't really be related to things they knew about anticipating, how ready they were, but there needs to be a discussion of what are the ways in which that's showing more than Medicaid expansion. It's showing other things because states that expanded are different than those. Maybe you try and match to states that so that's just one way to get started, but the other ways are much more individual level, thinking about who might have had, for example, easier access to employer health insurance. So think about bringing in unemployment rates, as has been done in previous literature. What could you do by interacting unemployment rates with the public health emergency and how that impacts Medicaid coverage just at an aggregate level. Another would be perhaps to bring in baseline conditions that many studies have used, even at the county level, baseline, and then a change happens, and then you see the interaction there. And then, as I mentioned, the using the March 18th cutoff is to say, look at all of the different events that make somebody eligible, and then have a date by which that condition ends. So one I've been thinking about doing is looking at postpartum coverage ends on a certain date. If that ending date was right before versus after, then there are two groups of likely similar people who then experience different pandemic rules coverage. So, but I think people come up with lots of cool things.
Yeah, those are great ones to kind of get thinking about. I wonder if you could tell us a little bit about your interactions with state administrators and policymakers in, especially in kind of the context of you had some of this almost real-time data or very fresh data at the same time that the kind of the policymaking context was incredibly dynamic. And so, we saw states, announcing one thing and then, could change a day later or a week later. And so probably a lot of this was sort of, they were updating based on what they were hearing. And some of, then I think there's a lot of, political climate that sort of affected these types of things. But, what was that like for you as you were sort of seeing these things and seeing, trying to gather the data and see the policy changes, happening at a really quite rapid pace? Can you tell us about sort of those engagements and that communication and what that looked like?
Yeah, so I think that it during a crisis or during any time where there's a greater need to try and know real-time information, then you find that many states move their own information systems so that their own decisions could be guided by faster access. So Indiana has made lots of improvements in their own data infrastructure to be able to have that. Sure, that's the case for every state. So we found it was nice because their infrastructure exists for us, for university researchers to talk with state offices about topics of public health, where there would be just an open call for, does anybody have any comments to make? And that became an easy venue to which we could say, oh, well, this data source, which is a national data source, but has a state, we can look at the state data from that and say, well, does that help you compare to other states how our own state is doing? So that's something I found is a way that state officials seem interested in knowing, if you are doing research on multiple states, that you can make this comparison for them that their own data may not be doing.
Great. And so I think, and maybe this is sort of my last question, unless other people drop things in, but you touched on coverage there. I think there was sort of an interesting and somewhat tragic paper in JAMA by Alyssa Belinsky and Emmanuel Ezekiel and one other author, where they were looking at excess mortality across the US and peer countries. And so the excess mortality for kind of the median peer countries was, something on the order of 50 or 60 deaths per 100,000, and for the US it was 145, so almost three times that. And even if you looked at kind of the 10 most vaccinated states, they split this out in kind of an interesting way. So they looked at the 10 most and 10 least vaccinated states. The 10 most vaccinated states, they moved up, but they're still in the bottom third or something like that. So, I think, so I guess as a country, we're not doing great, but there's probably some pockets of success. And so, aside from coverage, I wonder if you or the people you're working with or the state policymakers have started to think about, what else is there perhaps within Medicaid that is sort of protecting people, or what kind of success stories there are, other interventions beyond just coverage would be would be useful. I think, particularly in terms of health equity, that this sort of COVID kind of had a double impact or double whammy there. So, I guess, if you could sort of expand on that, beyond coverage, what other types of policies might be there for within the Medicaid world or for policymakers?
I think that when we think about health insurance, if we think of just textbook health insurance, we think of the tools we have as being essentially design of coverage. How much is the cost sharing? How are you going to have your network structured? But Medicaid is really different. It is this social insurance program. It's the program that has, of all of the social assistance programs, received the largest increase in possibilities. It has seen that options for expanding or have been, especially pre-pandemic. So thinking of the role that Medicaid plays in affecting social determinants, I think is where there is a lot of promise, because it's a population that reaches, it's a program that reaches the population that is the most at risk by definition. And so then here is an avenue, here's something that states are designing, that there seems political will to put effort into structuring, that we should take advantage of all those opportunities.
Great. Well, thanks. Well, I think we can let this close here, but I want to thank you so much for taking time and presenting this research, really important and powerful stuff. And I think a lot, they're sort of just getting started in some ways to really understand some of this going forward. So nice to see the thoughts about the research agenda. So thank you so much, Kosali, and David, let me pass it on to you for closing remarks here.